offer ma'am's made to me. Okay, Asranti ma'am, but just before I start, one question. Do you think he'll be able to manage to join on this, or will we have to like shift to another platform? Do you think we should give
No,
some time?
from his laptop, he is not able to join. I have asked him to join from the mobile at least. His laptop is telling not supporting this app or something like that.
Right. So while we give sir a few more minutes to join,
I'll ask him again.
thank Kim ma'am for letting me
Please
voice.
continue. Like Madam told you, please continue.
So that's the advantage of having an experienced chairperson of the thing. So now bone marrow failure syndromes, for the benefit of the residents who are here, don't just encompass. So let me start by defining the entity. So bone marrow failure syndromes are characterized by cytopenias. Okay. So in hematology, when you think of persons with a decrease in any of the three, which is hemoglobin, that is the RBCs, the WBCs or the platelets, then the causes could be at two levels. You can have a cause at the periphery, for instance, megaloblastosis, hypersplenism, things like that. Or you can have a cause in the bone marrow where production is getting affected. Now, production can get affected in two ways. One is that the raw material is not there. The stem cells that are supposed to give rise to these formed elements of blood, by which we mean the megakaryocytes, platelets, the erythroid cells for RBCs, and the granulocytic and monocytic precursors for WBCs, and the lymphoid progenitors. If they go away, then you get something called a hypocellular bone marrow or aplastic anemia. On the other hand, you can have these precursors present, but the maturation is defective, in which case you call it ineffective erythropoiesis, that ineffective hematopoiesis, which means that hematopoiesis is happening, but it is not translating into counts. Now, so these two latter situations, where the bone marrow is the cause, but you're having peripheral cytopenias, are known as bone marrow failure syndromes. Most people will exclude ineffective erythropoiesis from the classical marrow failure. Okay, so what is marrow failure? It is cytopenias arising due to the inability of the bone marrow to produce sufficient numbers of blood cells. Okay, it's failure of the marrow. The next question is, how do we classify them? There are several ways that one can approach it. One is at a very nosological or an etiological level, you can say that they may be inherited or they may be acquired. Right? So inherited can be divided into multiple, subclassified in many ways, but one of the common ways to do it is depending on the lineage that is involved. So you can have inherited bone marrow failure syndromes that present as pancytopenia, which means everything is gone, or you can have inherited bone marrow failure presenting as cytopenias of individual lineages. And
Prashant, can I just this inherited ones? This seen manifestation at what age?
Thank you, ma'am, for asking that. So inherited ones manifest at a very wide age, but typically most will present by 2 to 3 years of age, with a small exception of Fanconi anemia, which of course is a very common one. Now, Fanconi anemia is a multi-system disorder, as Kim ma'am obviously knows. I think she's asking the question for the benefit of the audience. So,
am I audible now?
Yes, sir. Thank you so much.
Am I audible?
Yes, yes.
Very clear.
You see, a little bit of piece of my suggestion. You see, Cisco WebEx is a very infrequently used platform for such meetings now, because most of the operating systems are not supporting it. So please do consider about.
Dr. Deepak, this is the first time we are having a problem with you. Nobody else had complained.
Okay.
Please continue your talk.
Yes. I'm just opening my presentation.
Sure, sir. Please take it. To the audience, I'd just say that we're very happy that Professor Mishra has joined us. I don't know if sir would have heard me earlier, but we were just discussing, sir, why you're the perfect person to be talking about this. We'll just wait for your slides.
So Fanconi's anemia, how frequently do you see, Prashant? Day-to-day routine practice?
We do get them from time to time.
Mostly in books.
We do see.
So, in fact,
We do see, and even autopsy had happened. I have done a CPC also. Because we referred cases, place, so we do see a lot of cases. So Prashant will have very good experience. So there is nothing, it's not a matter to laugh about. Who was laughing? Please tell, continue. One should learn to behave when one is in a formal meeting. Please continue.
Actually, the test that we use.
Yes, yes.
Yes.
No.
Please
Share
start,
your
if you are ready.
screen, share your slide.
Okay, ma'am, I'll take this up in the questions. We can let our speaker take on that. We see it regularly. If you test for it, you
We see regularly, even autopsies are done.
Mr. Please share your
Yes,
screen.
yes, yes. I am Cisco.
Dr. Deepak,
Yes,
Mishra,
yes,
great your laptops and everything, whatever you have.
yes. Are you able to see the presentation now?
No, yes.
Prashant has already introduced you, so you can start your thoughts.
Yes. I don't, he not have to repeat that. My good morning to everyone in this virtual audience. Am I audible now?
Yes.
Very much.
So,
Please go ahead.
my profound apologies for the technical glitch that I encountered at the beginning of opening the connection.
Please, Dr. Mishra, without wasting any time, please start your presentation.
Yes. Could you please be a little quieter? The title of the presentation today is Bone Marrow Failure Syndrome. And as you all know, that bone marrow failure syndrome is one of the important components of any hematology clinic. And most of the benign hematology clinics sees it as one of the most important and most challenging clinical problems in their day-to-day practice. With that brief introduction, I move to the next slide. I'm not able to move this slide. Slide is not moving. So bone marrow failure syndrome refers to the decreased production of one or more of the hematopoietic lineages. When you call pancytopenia, usually it is referred to as that there is reduction in all the three important lineages, that is the red cells, the WBCs, and the platelets. And this happens because of the diminution in the hematopoietic precursors in the bone marrow, and there is marrow hypoplasia, or there is a fatty marrow, or even in case of myelodysplastic syndrome, where there is bone marrow failure as well, there is a hyperplastic bone marrow. And if you talk about the prototype bone marrow failure syndrome, it is of two types. Either it can be acquired or it is seen in an inherited fashion. If you classify the bone marrow failure syndrome as inherited and acquired will constitute about 70% of the patients of BMFS, and majority of them are aplastic anemia, followed by PNH, pure red cell aplasias, and there are few more which I have not enumerated because of the rarity of those disorders. However, in the inherited side, the list is long. You start with Fanconi's anemia, which is the most common form of inherited bone marrow failure syndrome, followed by CDA, the congenital dyserythropoietic anemia, Diamond-Blackfan syndrome, dyskeratosis congenita, thrombocytopenia with absent redi, Costman syndrome, congenital amegakaryocytic thrombocytopenia, Pearson, severe congenital neutropenia, Salmon-Diamond syndrome. So I will be discussing a couple of them in more detail, leaving aside the rarer ones. So if you talk about the acquired bone marrow failure syndrome, as I said, that aplastic anemia is the prototype disorder which accounts for 70% of the acquired bone marrow failure syndrome. And this is characterized by chronic primary hematopoietic failure. Here, the bone marrow is hypoplastic to varying extent, and it is seen in the form of reduction in hemoglobin, which is usually below 10 grams per deciliter. Neutrophil count is fewer than 1500 per microliter. The platelet count is fewer than 50,000 and an absolute reticulocyte count is should be fewer than 40,000 per liter in absolute terms. These days, the smarter counters give you the absolute retic count as well. So it is no more a percentage that you express, rather you express it in terms of the absolute neutrophil count, absolute reticulocyte count, which is more important. The anemia, the aplastic anemia has been classified by a modified Cometa criteria, which classifies it into severe, non-severe, and before that you have very severe aplastic anemia. And this severity is expressed because of the bone marrow cellularity. Usually it is less than 25% in severe aplastic anemias. If it ranges between 25 to 50% of cellularity for age, usually the hematopoietic component is less than 30%. Plus, in addition, you should have at least two of the following three peripheral blood criteria being met. The granulocyte count should be less than 500 per microliter, platelets less than 20,000, and retic count less than 20,000 per cubic millimeters, along with the other bone marrow biopsy criteria. Very severe aplastic anemia is the same as above, as described for severe, but the granulocyte count is less than 200.
Excuse me, Dr. Mishra, please make it full screen, that slide.
No, full screen. If I make it full screen, unfortunately, the slide is not moving. So I don't want to waste time. So that's the reason why I haven't done so. Apologies for that as well.
Yeah.
So non-severe, I can try it again, but
so maybe we can try just once, because I think before you and just
yes, it is moving now. Yes.
Yes.
So now it is full screen.
Thank you, ma'am.
Yes.
So when you do not meet the criteria for severe and very severe, it is non-severe aplastic anemia. So the etiological diagnosis is quite varied as well. As I said, 70% of the cases of idiopathic aplastic anemia is because of the acquired nature, and they could be because of acquired stem cell defect, or it could be immune mediated. The secondary causes are also quite important. You can have chemotherapeutic agents like alkalytic agents, you have antimetabolites, you have benzene chemicals, which no more is used because of its toxicity to humans. Chloramphenicol is now history. Inorganic arsenicals is important because many places in the country there are arsenic contamination in drinking water, so this still is a problem. Physical agents like whole body irradiation in outside the purview of the therapeutic whole body irradiation, you could get chronic irradiation in places where there is background irradiation due to the presence of thorium at some places within the country, like Kerala and parts of Orissa and many other places where there could be background radiation. And that could and in and around the atomic reactors. These days, the atomic reactors are quite safe. However, there is a remote possibility of background irradiation in those areas. Many infections, particularly the viral ones, could produce bone marrow hyperplasia, most common being the hepatitis group of viruses, followed by the cytomegalovirus, Epstein-Barr virus, herpes zoster, could produce viral infection-induced hypoplastic anemias, inherited being Fanconi's I have described, and there are a large number of telomeropathies where there are telomerase defects, which I'll discuss briefly in one presentation. So if you look at this cartoonized slide, you can have exchanging on the left and intringing on the right. You can see that the exchanging is because of the immune-mediated suppression of marrow progression. The prominent publications are mostly from Professor Neil Young from the National Institutes of Health in the US. Here, what you see that there is a stem cell which is possibly abnormal, and it gets more abnormal because of the environmental insult like viruses and drugs, with genetically altered, and that expresses novel antigens. And because of that, you could get the T cells being activated, producing interferon gamma and tumor necrosis factor alpha that produces bone marrow aplasia or hyperplasia. And on the other side, you can have reduced proliferative and differentiative capacity of the hematopoietic cells leading to bone marrow aplasia. So intringing and extringing mechanisms help in the pathogenesis of acquired aplastic anemia. So this is the nutshell, the pathogenesis. I will describe in its completeness. You find that the black line is inhibition of the proliferation of hematopoietic cells, and the blue line is the stimulation of hematopoietic stem cells and the apoptotic pathways. And you, as I have already described about the role of interferon gamma in tumor necrosis factor alpha, the proliferation of naive CD8 positive T cells, and the downregulation of T regulatory cells, all contributing to the hematopoietic niche, and thereby there is decrease in hematopoiesis. Similarly, you can have stromal nest defects, which could be, as we talk about the seed and the soil mechanism of production of a plastic anemia. The soil could be bad or the seed could be bad. Hematopoietic stem cell is the seed and the stromal nest is the soil. And here you can have immunomodulatory defects happening. And because of that, there is decreased proliferation of hematopoietic stem cells. Clinical features. This being a postgraduate lecture, I have tried to make it as simpler as possible so that they, at the end of 1 hour, they should go back with some idea about what to write as and when there is a question of bone marrow failure syndrome. 3 presentations: anemia, leukopenia, thrombocytopenia, and their antecedent clinical features of pallor and e.g. fatigability, more susceptibility to infections of all kinds, and due to thrombocytopenia, there could be bleeding, which could be milder and which could be severe as well. As a rule, when you examine a patient of aplastic anemia, splenomegaly and lymphadenopathy are usually absent. If you have splenomegaly in a suspected case of aplastic anemia, then you should revise your suspicion and go for something else. Usually splenomegaly, extremely rarely, splenomegaly has been reported in aplastic anemia. Lymphadenopathy is usually not ruled, so this you must remember. And epidemiologically, there is no sex predilection in aplastic anemia where male and females are seen in equal proportions. This is a table that highlights the laboratory evaluation for aplastic anemia. You have various tests, and the rationale of the test is also mentioned on the right side. You do a CBC, which is the bread and butter for the diagnosis. Aplastic anemia is always a diagnosis of bone marrow biopsy. Many centers I have been to diagnose aplastic anemia based on just a simple bone marrow aspirate, which in any case is going to be either a blood tap or a dry tap because there is nothing in the marrow. So you don't aspirate anything when you aspirate the bone marrow. So aspirate can never be the test of choice for diagnosis of aplastic anemia. You have to do a bone marrow biopsy to establish that the patient has hypoplastic marrow or aplastic marrow. So bone marrow biopsy is the most important investigation to assess the cellularity and to assess the architecture of the marrow, because many times within the marrow, there could be granulomas, there could be some degree of fibrosis. You could also get hemophagocytosis. You could have metastatic deposits, which all could lead to bone marrow hypoplasia. Bone marrow aspirate, as I have mentioned, morphology is very important of these cells. You could have malignancies, you could have benign disease, you can have storage disorders, hemophagocytosis in the form of hemophagocytic lymphohistiocytosis, congenital disorders. Myelodysplasia is, though mentioned here, is usually not a hyperplastic marrow, but usually it is a hyperplastic marrow. But you have an entity called hyperplastic myelodysplasia. So many times you may have to differentiate between aplastic anemia and hypoplastic MDS. So thereby, this myelodysplasia has figured in this list, but you have to be very careful in labeling hypoplastic MDS vis-a-vis aplastic anemia. Cytogenetics is one of the most important investigations because many times this acquired aplastic anemia can mimic Fanconi's anemia because of dysmorphic features in the patients. I have seen patients of Fanconi's anemia as up to 40 years of age. So it is not that it is inherited marrow failure syndrome, but you can't see Fanconi's anemia at middle-aged population. Bone marrow culture is usually done for tuberculosis and viral diseases. Peripheral blood smear examination is important. The biochemical parameters is equally important to segregate the patients who are having hepatitis, liver disease, and the like. After all these, you have some esoteric tests which you need to do at times to arrive at the etiology of hypoplasia or aplasia. Ham's test, glucose lysis test are all historical tests now. Now you have better tests available, like you can do flow cytometrically a test for PNH, which will supplement the Ham's test and other conventional test. Then you have the bone marrow aspirate available to you, and you can subject it to chromosomal breakage studies by doing the stress cytogenetics. Thereby, you use two clastogenic agents. So one is the mitomycin C, another is the diepoxybutane. Our laboratory uses mitomycin C, and some laboratory use diepoxybutane. Diepoxybutane is banned into India has banned the entry of diepoxybutane into the country. So most of the reagent suppliers they are not able to give dioxybutane to you. I think PGI Chandigarh has it because Madam Neelam Verma got diepoxybutane when she had gone abroad somewhere and she managed to get it. I think that lab uses diepoxybutane, and Prashant will hear me out if it is correct what statement I'm making. Autoimmune diseases are an important source of acquired aplasia because collagen vascular diseases are there. Histocompatibility testing you do just to donor screen because bone marrow transplantation is the most important curative form of treatment in aplasia. Aplastic anemia is also known to be associated with multiple or a host of other clinical diseases. Autoimmune disease, as I described, is a very important condition where it could be seen. Immune diseases of non-autoimmune type also could have aplastic anemia. Thymomas is a very important cause of aplastic anemia. So thymic hyperplasia, and when you have it, thymoma, and there is aplastic anemia, you relate it to thymoma. PNH and aplastic anemia are brothers and sisters. They go together. I will show you a case which we encountered recently, and that will illustrate my point. Myelodysplastic syndrome, as I mentioned, though shows a proliferative bone marrow, is at times hypoplastic, and hypoplastic MDS is one of the closest differential diagnoses of aplastic anemia when you see and demonstrate some amount of dysgranulopoiesis and dysmegakaryopoiesis, dysmyelopoiesis in the peripheral blood as well as in the marrow. So blood and marrow findings are very, very clear. You usually get pancytopenia, but you also can get bicytopenia. So bicytopenia is good enough to give a suspicion of bone marrow failure syndromes. The red cells are usually normocytic, normochromic to macrocytic, normochromic. And there is profound reticulocytopenia being a feature of primary or secondary bone marrow failure syndrome. So bone marrow usually is markedly hypocellular to different extent, and the cellularity is usually expressed in terms of the patient's age. So the cellularity is the degree of cellularity should commensurate with the age of the patient. Usually when we in our practice, we always take 100 as at birth, and as you grow older towards 100 years, your cellularity decreases by that proportion. A 50 years individual is expected to have 50% cellularity, and a 20 years individual will have 80% cellularity, and in that way. So usually the marrow will show mostly scattered lymphocytes and plasma cells, hematopoietic elements being nearly absent, and the bone marrow stromal element will show the mast cells. So there will be increase in mast cells in the bone marrow stroma. So that's the classical description of a hypoplastic bone marrow. And in that, you can have fewer islands of erythroid precursors intermingled with some myeloid cells. And these erythroid precursors are usually seen in the hot pockets, and usually they show normoblastic maturation to mildly megaloblastic maturation. Megakaryocytes, by the rule, is always the first to be affected in any hypoplastic setting. So megakaryocytes you are less likely to see in a hypoplastic marrow. Since aplastic anemias are usually given supportive care, you will always find that the patient's bone marrow biopsy will show, or the aspirate will show, large numbers of hemosiderin-laden macrophages. They are not pathognomonic of the disease. They are because of the supportive care that they have received in terms of red cell infusions or red cell transfusions. This plastic megakaryocytes and granulocytic cells can be seen in aplastic anemia, but they're not usually seen, and that is the differentiation between hypoplastic MDS and aplastic anemia, which is always a difficult differential to make. This is the way how a bone marrow biopsy look like in very severe aplastic anemia. The bone marrow cellularity here is less than 5%. You can see only the chinks of those vascular spaces, and there are hardly any hematopoietic cells. And if you go to oil immersion, you can possibly find occasional erythroids and occasional myeloid cells. So the point here to remember is that aplastic anemia is always a diagnosis of bone marrow biopsy. I am appalled to see that many centers they make an attempt to make a diagnosis of aplastic anemia purely on the basis of a dry tap or a blood tap in a bone marrow aspirate examination. So biopsy is mandatory for the diagnosis of aplastic anemia. This is the fundamental rule of the diagnosis of aplastic anemia, and the biopsy should be adequate by being at least 2 centimeters in length. Subcortical marrow should never be examined for the diagnosis of aplasia because the subcortical bone marrow spaces are usually hypercellular. So if your bone marrow biopsy is of appropriate length, you will always exclude the subcortical marrow spaces and will go into the deeper marrow spaces for the cellularity assessment. So management, I'll not go into the detail because it is not within the purview of this, but primarily they are immunosuppression, they are androgens, and in case there is affordability of the patient, patients usually receive L-Trombopac, which is a thrombomimetic agent or a thrombopoietin analog, which very few patients receive in our settings because it is expensive and the long-term treatment makes it unaffordable to majority of our patients. Otherwise, supportive care in terms of infection control by antibiotics and supportive care in terms of component transfusions, in terms of platelet concentrates, red cell transfusions are most important part of the treatment of aplastic anemia. And very rarely, some centers, they do granulocyte transfusions if there is fulminant infections of fungal type or bacterial type, which is resistant to very high-grade antibiotics. With that, I complete the prototype disorder of the bone marrow failure syndrome. That's aplastic anemia. As I said, that aplastic anemia and paroxysmal nocturnal hemoglobinuria are brothers and sisters. They almost go together. 25 to 30% patients of aplastic anemia and 25 to 30% of patients of paroxysmal nocturnal hemoglobinuria have interchangeability. So acquired hemolytic anemias can be seen in aplastic anemia. PNH can have phases of aplasia, and aplastic anemia can phases of PNH, because when the aplastic anemia is in the phase of PNH, usually the bone marrow shows a little better cellularity when you examine the marrow. So PNH is characterized by hemolysis, and that is intravascular hemolysis, venous thrombosis at unusual sites, and pancytopenia as it is seen in aplastic anemia. So pathophysiologically, it is very, very simple. Most of the postgraduate students answer this question very beautifully because it is because of an acquired mutation in the PGA gene in the hematopoietic cell. And what is PIG? You all know that this is a gene that encodes for the GPI-anchored protein. And if the mutation burden increases, the result is there is a clonal proliferation of the GPI-anchored deficient cells, which is actually susceptible to complement-mediated lysis. And this GPI-anchored proteins act as receptors, complement regulators, and they are also adhesion molecules. So when you analyze or assay them flow cytometrically. The CD55 and 59, which are the two prototype antigens, which are GPI-anchored proteins, you always look for them in the red blood cells. You also look for many other CD markers in the neutrophils as well as in the monocytes. I will show you a slide later as to how you look for them in flow cytometry. So once the CD55 and 59 are markedly deficient in PNH, and these red cells become highly susceptible to complement-mediated destruction, thereby producing hemolysis and anemia. And this is a publication by Neil Young from the NIH, who is the dada of PNH and bone marrow failure syndrome in the whole world. So clinical presentation wise, you get patients who have a combination of hemolysis and bone marrow failure producing anemia. You have thrombotic episodes, either hepatic thrombosis, portal vein thrombosis, mesenteric splenic, cerebral thrombosis, hepatic vein Budd-Chiari syndromes are quite common in these PNH. Gastrointestinally, you have anemias, you have abdominal pains, you have esophageal spasm, you have dysphagia, and you have many other conditions. You can get it in PNH, and the other manifestation is that you can have gross hemoglobinuria and thereby producing renal tubular damage. So next is the diagnosis. CBC, of course, goes without saying. Liver profile, bilirubin because of the intravascular hemolysis. LDH will always be elevated. Retic count is also elevated, even though there is bone marrow hypoplasia. So there will be some degree of reticulocytosis in PNH. And when you do urine examination, which is often ignored, this is one of the most affordable, simple tests that can be done in most laboratories, is looking for hemoglobinuria and also urine for hemosideruria. Because when you look for the pulse reaction on the urinary deposit, you can find that those epithelial cells laden with hemosiderine granules because of chronic intravascular hemolysis. Flow cytometry, I will show you in the next slide, will identify the GPI-AP, GPI-anchored protein deficiencies in the peripheral blood. Treatment, I'll not go into that, but I will just highlight the biotherapeutic that is available currently because eculizumab, and there are many eculizumab analogs that have come out recently in the market. However, this drug is phenomenally expensive, one of the most expensive drugs in the world. So this is against complement. So the complement-mediated hemolysis is taken care of, and the patient has to take it lifelong. So it is unaffordable for most of the patients in the Indian setting. Allogenic stem cell transplantation in younger patients who have severe PNH are usually the curative form of treatment, and some of the patients have been transplanted in India with patients of PNH, including our own hospital has done one patient of severe PNH, and we have done a mud transplant for such a patient, and the patient is doing quite well. Primary thromboprophylaxis is important because the patients often thrombose. This is the case that I was referring to, a 15-year-old boy with chief complaints of weakness, pallor, and had subconjunctival hemorrhage. Received 3 units of PRBCs and 2 random donor platelets for the thrombocytopenia and anemia. Patient had no organomegaly and no lymphadenopathy. CBC 7.2, hemoglobin 1600 neutrophils, and platelets are 90,000. The bone marrow aspirate was hypocellular, hemodilute with predominance of lymphocytes and plasma cells with very few erythroids which were normoblastic in maturation. And this is the picture that you see, the bone marrow aspirate showing purely hypocellular fragments which are mostly constituted by the stromal lipocytes. And on the right side, you can see the bone marrow biopsy. Cellularity is less than 5%, hardly any. You can see a hotspot here where few erythroids are there. So cellularity is very less. This is the scatter plot of this particular patient where we do the PNH assay, and you can see that these are the granulocytes, monocytes. And when you see this CD14 and FLAIR, and these are the monocytes, this blue cluster, you can see that this is the PNH cluster. And here also you have, these are the granulocytes. This is flare with CD55. You can see this is the PNH cluster. This shows no flare, no CD55. This shows no flare and no CD14. So monocytes and neutrophils are showing deficiency of the GPA-anchored proteins. And so this aplastic anemia patient has a PNH clone. And when you have PNH clone in aplastic anemias, these are this cohort of patients who respond beautifully to immunosuppression, either to antithymocyte globulin or to cyclosporine A. So patients prognostically behave much better if they have a PNH clone. So the third entity which is important, and you often see it in a busy hematology practice clinic, is pure red cell aplasia or PRCA. Even though it is a rare disorder, it presents fairly commonly in many clinics. It is usually secondary to the failure of erythropoiesis, as has a syndromic characterization. Usually the anemia is normocytic, normochromic. Reticulocytopenia is profound, less than 1% reticulocyte count, or you can say that less than 40,000 per microliter. Complete absence of erythroblast from the bone marrow, less than 1% erythroid cells. And usually these erythroid cells are early erythroid cells in the marrow or even pro-normblast. So intact precursors for platelets and leukocytes, like the myeloid cells and megakaryocytes, are usually normal in numbers and morphology in this peripheral in the bone marrow aspirates. Predominantly, it is erythroblastopenia in the marrow. So when do you see pure red cell aplasia? Congenitally in diamond Blackman anemia or DVA, and in the acquired forms, you can see it in autoimmune disorders, in collagen vascular diseases, you can see it in leukemias. And when in leukemias, you do hematopoietic stem cell transplantation, you can have transplant-induced pure red cell aplasia because of ABO mismatch transplants, and is because of haploidentical transplant that is being done more and more in clinical practice. So both ways it can, leukemia itself can produce PRCA, and the therapeutics of leukemia in the form of HSCTs also can produce pure red cell aplasia. Lymphoproliferative disorders of all varieties, including multiple myeloma, solid tumors like thymomas, viruses like parvovirus B19, drugs when you give recombinant erythropoietin, pregnancy, and vitamin B2 deficiency, all can produce pure red cell aplasias. And here I would like to say that when you have parvovirus B19, you have the characteristic feature, which I'll show you in the next slide. So sometimes you can have transient aplastic crisis in other hematological disorders. Like say you have a patient of sickle cell disease, you have a patient of thalassemia, you can have transient aplastic crisis in them. And that is because of parvovirus B19 infection. And parvovirus B19 virus usually binds to the P antigen on the erythroid progenitors. And this acts as a receptor for the entry of the virus into other cells, other erythroid cells. And these cause lysis, leading to arrest of differentiation of the erythroid progenitors of the pro-normoblast state. That is why what will happen, you will not see any cell beyond the pro-normoblastic phase. So you'll only see the early erythroid forms. The picture shows you below that's the proerythroblast, which has got the dog ear-like projections of the cytoplasm, and you will have a prominent nuclear inclusion, which is nothing but the parvovirus B19. So they are usually seen in other hematological disorders which are of inherited type, like thalassemia, sickle cell disease, hereditary spherocytosis, who are transfusion dependent. So infection with parvovirus B19 can induce a transient phase of aplasia in these hematologic disorders. So when you look at the bone marrow and you see that only the pro-normoblasts are seen in the marrow and they have a prominent nuclear inclusion, so you must suspect parvovirus B19. And if you do the parvovirus B19 serology, they will always show increased parvovirus B19 antibodies in the serum. So the next entity is seen in a pediatric setting, which is called the transient erythroblastopenia of childhood. This occurs in previously healthy children, younger than 8 years of age. Usually they are seen below 1 year of age, 1 to 2 years, and they are a self-limiting condition and they resolve on its own without any treatment. So this is again immune-mediated mechanism that is implicated in the pathophysiology of transient erythroblastopenia of infancy, it is called, where both IgG and T-cell mediated mechanisms play a role in the causation of this transient erythroblastopenia of childhood or infancy. So that includes the acquired causes of bone marrow failure syndrome, and I will move on to the inherited forms. I have gone a little faster because to make up for the loss of time. So in case you have any doubts on any of the conditions that I have so far discussed, you are please free to ask at the end of the discussion. So I move on to the inherited bone marrow failure syndrome, which are again a heterogeneous group of disorders, which are characterized by qualitative and quantitative abnormalities affecting one or more of the hematopoietic lineages. Usually they are caused by germline mutations. You all know that mutations are of two types. Either it is somatic mutation, which is usually acquired, and you can have germline mutation where the mutation is present in most of the cells of the human body, which is called germline. So germline mutations affect the structural proteins which are key to the cellular pathways, such as the DNA reparative mechanism, the telomerase biology, and the ribosomal biosynthesis. I will come to that one by one in my subsequent presentations. And here, I must say that these disorders usually manifest early in life, often at birth, being congenital in nature. I just described Fanconi's anemia in the classification, and I said that in my practice, I have seen a patient of Fanconi's anemia at 40 years of age. So it's truly inherited, but it can be seen at any age if you suspect it. So this is a slide that tells you about the inherited bone marrow failure syndromes producing pancytopenia, inherited bone marrow failure producing single cytopenia. So Fanconi's anemia, dyskeratosis congenita, Swamman-Diamond syndrome, reticular dysgenesis, Pearson syndrome, familial aplastic anemia, which is autosomal as well as X-linked forms, myelodysplasia, and non-hematological syndromes like Down, Dubovich syndromes, all can have pancytopenias. But you do get single cytopenias, as I have already described. A form of pure red cell aplasia is called diamond black fan. You can have congenital dyserythropoietic anemias or CDAs. CDAs can be of many types: CDA type 1, type 2, type 3. It goes up to even type 8 CDAs. Neutropenias, usually it is severe congenital neutropenia, including the Costman syndrome. Thrombocytopenia, I mentioned about a megakaryocytic thrombocytopenia with absent redi and congenital megakaryocytic thrombocytopenia. So Fanconi's anemia is the prototype disorder in this category, and it is an inherited aplastic anemia, which is because of the genomic instability. Because of the chromosomal fragility, this is also called the what you call as chromosomal instability syndrome. You have Fanconi's anemia, you have dyskeratosis congenita, you have Bloom syndrome, you have ataxia telangiectasia. All disorders are because of the chromosomal fragility syndrome. So chromosomal fragility of breakage with a defective DNA reparative mechanism is the cause of the pathogenesis of Fanconi's anemia. So the bone marrow cells progressively are underproduced and they produce peripheral pancytopenia. And along with that, because of the developmental anomalies, you can have dysmorphic features and it will have a stronger propensity for hematologic and solid tumors in the future years. So this is also a pre-neoplastic state where other malignancies can appear in the natural history of the disease. So it has congenital anomalies, it has pancytopenia, it has increased susceptibility to cancers. So 98% of the Fanconi is an autosomal recessive disorder, and only 2% are X-linked recessive. So predominantly it is autosomal recessive disorder. Overall prevalence is about 1 to 5 cases per million births with a carrier frequency of 1 in 200 in most populations. Occurs preferentially in some races, particularly in the Ashkenazi Jews and some African population in South Africa. Equal incidence in males and females being an autosomal disorder. So genetically, what happens is that the mutation, I'll come to that table in the next slide, the FANC gene mutations. The mutation in a group of genes called the complementation group are responsible for this DNA damage repair by the homologous recombination repair mechanism, or HRR. And it is because of the interstrand DNA crosslinks which are not able to be repaired because of the defective HRR process, or the homologous recombination repair mechanism. It is also seen in many solid tumors where you can have drugs targeted against them. You can have it in high-grade serous carcinomas of the ovary. You can get it in certain colorectal malignancies. So now these days they look for these HRD, they call it, the homologous repair mechanism defect, HRR proficient or deficient. So when these genes are mutated, crosslinks remain unrepaired, and when exposed to strand separation during cell replication, the chromosomal instability either makes the cell unviable to live further and die. And as a result of that, you will produce hyperplasia in the marrow. No cells are going beyond a certain stage. So those exposed ends lead to activation of Salve's non-homologous end joining pathways, which is a form of homologous repair recombination process. And there is fusion breakage cycles, and they produce massive aneuploidies. As you know that you can have these what you call as disomies, uniparental disomies, homologous, what you call as it is UPDs actually, which is seen in large number of hematologic disorders as well as in solid tumors. And as I have said that you do the chromosomal breakage analysis by using clastogenic agents like myromycin C and diepoxybutane. And it will show, I'll show you a picture that it produces chromosomal breaks which doesn't get repaired. And when the chromosome breaks, the end of the breakages are very sticky and they will stick to the other breakage components of other chromosomes, thereby producing radial formations. And by counting the radial formations, you come to a conclusion that there is chromosomal breakage syndrome. Other than that, there are abnormal cell cycle kinetics. Majority of the cells remain in the G2 phase. So G2 phase is prolonged. And these cells, or these progenitors, are very hypersensitive to oxygen, and increased apoptotic nature of these cells have been documented. So this is a cartoonized form of the entire pathology that is seen in Fanconi's anemia. I'm not going to the details of it. You can see that this is self-explanatory. There are few genes. The FANC group of genes, either FANC-D2 or FANC-I, are responsible for this pathway. This is the complementation group, which I'll show you in the next table. And this is because whenever there is a DNA replication that encounters a interstrand crosslink in DNA, the homologous repair mediated repair and replication restarts. And when that is defective, you get the Fanconi's anemia process started. And because of that, you get hyperplasia. So this is the FANC-A complementation group. Prashant's department in PGI Chandigarh does this very well. The CMC Velo does it. We do the stress cytogenetics in our lab using the myromycin C, but we don't do the complementation assay. But we are now standardizing the FANC-T ubiquitination assay in our lab. And that is the second stage of failure of stress cytogenetics. I'll come to that later. And the FANC-A genes are a group of genes, and the ones in red It gives you the percentage. FANG-K is the most commonly mutated, 60% of the patients. FANG-C is the next is 15%. You can have this BRCA2 FANG-D1 mutation seen in about 5% of the patients with Fanconi anemia. And this BRCA2 and FANG-D1 is also seen in ovarian cancers and in endometrial cancers in colorectal malignancies. FANG-G is seen in about 10%, and other FANG-A genes or the FANG genes are rarer in nature. And the site of the chromosomal location is also mentioned in the last column, which is not so relevant to you in this presentation. So what is the genotype-phenotype correlation in Fanconi's? The clinical severity is partly determined by the specific gene involved and by the type of mutation. So when you have homozygosity for FANG-K, you have earlier onset anemia and there is increased chances of leukemia. So they will progress gradually to a leukemic process if you survive for a longer time. So FANG-C shows also severe form of disease, early onset anemia, bone marrow failure, and also it leads to severe physical abnormalities. So more dysmorphic features are seen in FANG-C mutated Fanconi anemia. So FANG-D1 and BRCA2, as I have already described, is seen in more solid tumors, acute myeloid leukemias, and severe physical abnormalities. So when you do the germline assays for solid tumors, like BRCA1, BRCA2, this PALB2, and other, there are almost 21 ACMG genes which are mandatory to be tested in hereditary breast ovarian cancer panel. So they will all be showing these mutations. And FANG-D2 and FANG-I show severe abnormality. So clinical features, as I mentioned, is these genes are involved in both hematopoiesis as well as in non-hematopoiesis. The manifestations also can be non-hematological and hematological. So in the hematological, you know that there is bone marrow failure, so you'll have cytopenias. Red cells will be macrocytic because most of the aplastic anemia red cells are slightly having higher MCV. And mostly they will progress to aplastic anemia, MDS, AML. Similarly, in the non-hematological manifestations, solid tumors, squamous cell carcinoma, head and neck, skin, GIT, genital tract, particularly ovary, GITs, colorectal, CRCs. Endocrine disturbances can be seen because of the growth hormone deficiencies and hypothyroidism, hypopituitarism, and the early onset diabetes mellitus. So I will skip this slide. I have already said that you will have skeletal, skin, genitourinary, craniofacial, gastrointestinal abnormalities in majority of these patients. So diagnosis, peripheral blood bone marrow finding is as good as any aplastic anemia. So you will do the same peripheral blood study and the bone marrow biopsy aspirate. Classic chromosomal breakage test on peripheral blood lymphocytes, as I mentioned, the stress cytogenetics. In our lab, we have moved to this FANG-D2 monoubiquitination assay, but it is not complete. Still, you have to do the mutation analysis because this will not also resolve all the cases. So this is usually done the ubiquitination from the peripheral blood lymphocytes or skin fibroblast. Skin fibroblast is better because that will avoid, sometimes you can have mosaics. So when you have mosaicism and Fanconi anemia, your peripheral blood lymphocytes can miss this monoubiquitination, or even chromosomal breakage tests in Fanconi anemia may be negative. So mutation analysis is the ultimate test to be done if both the above tests are negative in highly suspected cases of Fanconi anemia. So this is how the peripheral blood will look like. You'll have macrocytosis, you will have increased fetal hemoglobin. So fetal type of hemopoiesis, any congenital or inherited disorders in hematology, it produces higher HbF. Just like your juvenile myelomonocytic leukemia, you look for higher HbF percentage. So this is the bone marrow biopsy. It is again just like aplastic anemia. You will have some degree of dysbiosis in some of them. And these are the ones which progresses to myelodysplasia earlier. Usually myelodysplasia is a disease of the 6th and 7th decade of life in the Western population. It is about a decade earlier in the Indian population. And when it is Fanconi's anemia, it is even a decade or 2 decades earlier than the standard myelodysplastic age. So Fanconi's anemia is predisposing to earlier MDS and acute myeloid leukemia. So disease progression, the bone marrow hypocellular and fatty is classical of anemia. This is the one that I was referring to. If my cursor is moving right, you can find that this is the radial formation. Okay, so this is triradial. This is also a radial formation. So the sticky ends will stick to each other and produce this radial formation. This is a chromatid break. This is the centromere of the chromosome, and you can find that these are the quadrilateral chromosomes, triradial formation. So metaphages showing radial formation and breaks are the characteristics of Fanconi's anemia, and not any chromosomal metaphase spread you see, you can find sometimes chromosomal breakages, but that doesn't mean that it is stress cytogenetics positive, because you have a way how you calculate it. So usually when you do it with mitomycin C and diepoxybutene, in a positive test, it is considered positive if the percentage of aberrations is 7 to 10 times higher than the normal. So you always take two sets of samples of peripheral blood lymphocytes, one a patient sample and a control sample, age and sex matched control, and then you subject it to the test. So a positive test will have 7 to 10 times higher forms of breakages in Fanconi's anemia. So 10 to 15% of the patients with the clinical phenotype of Fanconi's anemia may not show the chromosomal breakage test to be positive when tested with the diepoxybutene or mitomycin C. In this situation, the next assay is the FANC D2 ubiquitination test, which is a Western blot test, which is done in all advanced centers of hematology in this country. And after that, if this also fails, then you do the mutation analysis. So if Fanconi's anemia is strongly suspected, usually instead of a peripheral blood lymphocyte, you must do a skin biopsy, a full thickness skin biopsy. So we take the skin fibroblasts to do the monoubiquitination assay to establish Fanconi's anemia. And that also will circumvent the problem of mosaicism in some of the patients of Fanconi's anemia. So suggested diagnostic strategy for evaluating Fanconi's anemia in bone marrow failure syndrome is this table. As I mentioned, you have seen here chromosomal breakage test in blood, FANC D2 monoubiquitination by Western blot. These days they are non-radioisotope based Western blots, so it's very simple and safe to do in most laboratories. And if you find no breaks or no positive FA sign, negative test in blood and all, so you have all the other assays. And finally, you reach to the mutation analysis. That is the moral of this particular table. So treatment, I'll not go into the details. As I say, in any bone marrow failure syndrome, the first curative form of treatment is hematopoietic stem cell transplantation. If you do not have a donor available these days, the truncated family size has produced a unique situation that you don't find related sibling match donors. So either you have to go for a mud transplant from an international registry or the Dhatri registry that is in India, or you have to do a haplotransplant, which most of the Chinese centers do, because in China, because the one child family norm, they don't find matched donors, so they do haplotransplants in the maximum, in the largest number of haplotransplants are done in China. Androgen growth factors, and you have to put the patient in surveillance for solid tumors. You have to do them counselings, periodic counselings of their particular condition. So then after that, I land with diamond Flackman anemia. I've already mentioned about it, so I'll just rush through it, that this is anemia which is usually macrocytic. This is a disorder which is called a ribosomopathy. And ribosomopathies are a group of disorders which has, including diamond blackfan anemia, many other disorders. They usually present in early infancy with signs and symptoms of anemia, failure to thrive, and associated somatic abnormalities. And again, you have selectively decrease in the erythroid precursor. This exactly presents like a pure red cell aplasia that I have already described. So what is genetics? I have mentioned about ribosomopathies. It is a defect in the ribosome biogenesis, which then leads to increased apoptosis of the cells. And there is usually upregulation of the proto-oncogene of P53. So since the early apoptosis happens of the erythroid precursors, you don't find them in the bone marrow. And this is all because of the ribosomopathies. And the most common ribosomopathy seen in diamond blackfan anemia is the RPS19 gene. RPS is ribosomal protein sequence 19. In addition to this, you can also have other ribosomal protein sequences being abnormal. So the other commonest form is the ribosomal protein ligand 5 mutation, which produces multiple physical abnormalities, including craniofacial, thumb, and heart abnormalities. So sometimes diamond blackfan anemia, in addition to just pure and simple anemia, can have all these dysmorphic features. And sometimes you can have thumb abnormalities, classically seen in heterozygous mutations of ribosomal protein ligand 11 mutation. I will not go into the detail. You have dysmorphic features like this, a fist-like smile, and a pointed chin, bifid thumb. So if you have all these, you must suspect, and when the patient is anemic. So physical examination of a child is extremely important when the child presents to you with anemia. Treatment are not good. Treatment is very simple. Diamond blackfan anemia dramatically responds to corticosteroids in what you call short durations. 2 weeks to 4 weeks of treatment of corticosteroid, just dexamethasone or even prednisolone, will cure this anemia. But they will recur. So again, you have to reinstitute corticosteroids. So periodically, you have to treat them with steroids, and before the hemoglobin rises, you may have to support them with blood transfusion. Splenectomy very rarely may be indicated, but that's not the rule. Hematopoietic stem cell transplantation who are refractory to steroids are to be done. Dyskeratosis congenita is again a inherited bone marrow failure syndrome, and this is a disorder in which an Indian is involved. He's in Hammersmith Hospital, and he runs the International Dyskeratosis Congenita Registry. This is an inherited multisystem disorder. Primarily, the skin is involved, and along with that, you have bone marrow failure syndrome. So, clinical features are usually pulmonary fibrosis, hepatic fibrosis, and gradually these disorders, just like Fanconi's anemia, progress to AML-MDS or MDS-AML. Last presentation is on telomeropathies. As you all know, that telomeres are at the end of the chromosome, and they are actually non-coding in nature. They are the non-coding gene is hexanucleotide, TTA triple G, in tandem repeats at the end of the chromosome, and the associated proteins are termed as cell trains, and a secondary structure termed the T-loop. I'll not go into the details of that because that may be a little too much for this presentation. So as you know, the telomere length is actually called a mitotic clock. Every time a cell divides, the telomere length decreases. That is why as you age, you have higher telomerase activity and your telomere has shortened. So now a lot of people are working how to prevent this aging by tackling the telomerase enzyme. So telomere shortening is associated with aging. All of you know this. And everybody is working as to how to remain as young as possible by controlling the telomere shortening process. Tumor genesis is again related to this. As you age more, you are more prone to get cancers. So telomere is indirectly responsible for higher propensity to get cancers. And this is also responsible to produce bone marrow failure syndromes by telomeropathy. So telomere shortening happens with every cell division, and this is a cartoon that tells you as the cell divides, your telomere gets shortened. You see here the telomere is in yellow, and you see at the end of so many divisions, your telomere has shortened. So this is called telomeric erosion. So mechanism that leads to the dyskeratosis congenita is because of the decreased telomerase activity. Most common mechanism, and in addition to that, you can have the impaired telomerase recruitment to telomeres and impaired telomere duplication. So inheritance is again X-linked recessive, autosomal dominant, depending on the different genes that are involved. If DKC1 is involved, it is X-linked. If TERC, TNF2, and NF1 is involved, they are all autosomal dominant and recessive in that. So doing a clinical exome sequencing in anemia will do all this. So when you ask for in a rare disease setting to know what phenotype is this or what genotype is this, so you will do all these mutations, and that will tell you whether you have a rare disease and that is producing the anemia. So laboratory evaluation, as I mentioned, that since this is a telomeropathy, telomere length assessment is very important. And telomere length is now has become a standard of test in most Western laboratories. So we have been at this in our laboratory for the past 1 year. We are trying to standardize the telomere length assessment by two mechanisms. One is by something called flow fish. Another one is by a real-time PCR platform, by doing a real-time technique. We haven't been able to put it in the clinical scale reporting yet because we are still in this standardization mode. And I'm sure Prashant will bear me out. They're also looking at the flow fish for telomere length assessment. So bone marrow biopsy will be same as any aplastic anemia. Method of assessing telomere length I just mentioned. Terminal restriction fragment on southern blot, gold standard, but none of the centers do it. Extremely cumbersome. Learning curve is very high, difficult to standardize. Fish with immunostaining, that's the flow fish. The flow fish is the last flow fish is most useful. Single telomere length analysis is by the RQ-PCR. So third and fourth are the usual techniques that are used by most of us. So treatment is different. Soman diamond is again the same, which is again like pure red cell aplasia. Again, it is autosomal recessive. SBDS gene is mutated in chromosome 7. So bone marrow dysfunction happens. And you also have other phenotypic abnormalities like pancreatic insufficiency, and it moves to MDS AML. Laboratory findings are the same. I will just leave that. Surveillance for leukemia should be performed. Simon syndrome is characterized by high propensity to develop MDS AML. So that is how inherited bone marrow failure syndrome with predominantly anemia can be handled by CDA. CDA, I will not go into the details because I think I have reached 12:20. That's Madam Masrantika's deadline that I must finish by 12:20. So CDA, I think itself is a presentation because it's a large topic. Varieties of CDAs, CDA type 1, type 2, type 3. It has gone up to type 8 now. And this is again only anemia. And it has a genetic basis. And that I think will be subsequently the most common are the CDA type 1, 2, and 3. CDA type 1 is the most difficult to diagnose because the dyserythropoietic features are so subtle in the bone marrow aspirate smears that you may miss flows. You can do electron microscopy to see the Swiss cheese pattern of the nucleus of the erythroid cells, but not many do the electron microscopy for the diagnosis. HEMPAS, anti-I expression, small I antigen expression, these are all investigated. You see, this is how it looks like. You see internuclear bridges. you can have this bridge. This is the Swiss cheese pattern, and this is the internuclear bridges. You see, this is the bridge between two erythroid cells and the nuclear interconnected by the internuclear bridge. So these are the things that has to be looked for. If you have too many of these in a particular smear, then the diagnosis is easy. Otherwise, CDA type 1 is the most difficult to diagnose. CDA type 2 and type 3 are more dyserythropoietic, so easier to diagnose. So you can have gigantoblast in CDA type 3, as you can see here. This is a gigantoblast, multiple nuclei in the same cell. So I will not go into the details of that. Pearson syndrome is again is a mitochondrial disease. It is maternally inherited, and as you know that many of you may not possibly be knowing that mitochondria in the human body are maternal in origin. So they are maternally inherited mitochondria. Cyclic neutropenia is again very important. Costman syndrome, at least I have seen about 4 or 5 of them. This is called cyclic neutropenia. Many times neutropenia it comes in a cyclical manner, and you just have to think about it and do the gene analysis for HARTS1 and G6PC3 genes. So at the end of this presentation, I would like to say that not only morphology is important, phenotype is important, genotype is even more important, because today if you have a rare anemia which you are not able to arrive at a conclusive diagnosis, everything boils down to clinical exome sequencing. And in a setting of anemia, when you ask for a clinical exome sequencing, large number of genes are studied to say that this particular mutation is possibly seen in this. So they will tell you whether it is pathogenic or likely pathogenic, or there is a variant of unknown significance. So Costman syndrome is also important in terms of cyclic neutropenia I just mentioned. So they are also genetically inherited. Treatment is again GCSF. So I'm leaving out all this. I have just seen one patient of thrombocytopenia with absent redi, that too at King's College in London, when the patient used to come off a follow-up. The radius was absent and patient was thrombocytopenia. In India, I haven't seen in my almost 30 plus years of hematology practice. A megakaryocytic thrombocytopenia is again a bone marrow aspirate and biopsy diagnosis. With that, I end. And I have deliberately rushed through the last couple of slides to save time and generate questions. Thank you very much. And I'm again apologetic for going through that technical glitch at the initial time of my presentation. Thank you so much. And in case there are any queries, I would love to answer a couple of them.
Thank you very much, sir. And absolutely no reason to apologize. Technology gets us all in the end. I think it eases life, but it can also be like so exasperating. So it's perfectly okay. And thank you so much for the wonderful talk. You've covered almost every aspect that I can think of in the bone marrow failure syndromes, the acquired, the inherited, the ones who come with pancytopenia, the ones who come with single lineage problems. And I can see some people applauding in the corner. So are there any questions from the audience? I would request you to raise your hand. It's possible to do so if you see the panel below. I can also see many senior people in the audience. So if you have any, so we'd also love any comments. We have some very eminent GI pathologists. I don't want to take names because I'd never take all the names and people, then it's not nice. Yes, please.
Prashant, you're talking of GI pathologist or hematopathologist? Is hematopathologist. But anyway, in hematology, I think I fully agreed. I just want to make a generalized comment. I fully agree to what Dr. Mishra said about a molecular for hematology, right? Hematological cases. But I think the same thing may not be really true with respect to the histopathology and cytopathology, because morphology is the basis for those. But for hematology, possibly you need the flow, you need the cytogenetics and the molecular. So I think he is talking definitely in context to hematological problem. Very well presented, Dr.
No,
Deepak. Thank you very much for taking so much of your time to make your slide.
Dr.
You
Kim,
are not listening to me. You are not listening to me. Let me finish.
Yes.
You are impatient with others, but you expect everybody to wait and listen to you. I
Please.
am appreciating you. I said, thank you very much. You have taken out so much of your time to make so many good, beautiful slides for IAPM. You are working for me and for Dr. Sranti. Thank you very much.
Thank you, madam. Actually, very exhaustive talk, and
Yes.
we have
Yeah,
included
we
all
have
the
to
entities.
appreciate.
It was
Yes.
We
truly
have
a
to
pleasure.
appreciate
I
Dr.
can
Mishra's effort.
discipline that.
So, can I say now or I'll wait?
Oh, definitely, please go ahead.
I have a small disagreement with you that even in solid tumors, today genomics has taken center stage. Of course, morphology will remain and remain and remain. But you see, today, neuro-oncology, everything is genomics. Today, you cannot do away with MSI, and today, you cannot do away with homologous repair recombination mechanisms. Today, you cannot do away with your NRAS, KRAS, and other things, IDH in colorectal malignancies. So, everything, either it has diagnostic value, or it has therapeutic value, or it has prognostic value. Today, morphology has to be supplemented with genomic medicine. I think we have to accept that, and our younger crowd should be encouraged to read more of the genomic part of the morphology and should correlate the morphology with the genomics. Then only they will survive in the current world.
Thank you, sir. That was
Survival, I agree fully, but we also do all those things which you talk about routinely, right, Dr. Mishra? We do everything much more than that on routine basis, but you decide what you have to do based on your morphology. You cannot decide randomly.
I think two wonderful personalities discussing. We're loving it, but we will run out of time very soon.
Yes, tell.
So
Continue.
I think I'd just like to, since there don't seem to be questions from the audience so far, there's a lot of appreciation. Thank you, Dr. Danish. So
There is
There are more
one, I
questions.
think, Dr. Prashant, there is one chat. Just see in the chat box, there is one question.
I checked.
No, madam,
ma'am,
there are no
there are
questions,
comments.
only one
Just
appreciation. There are
Yeah.
appreciations. And it seems Dr. Mishra has made everything clear to the audience and also to the residents. No questions so far. It was very well explained, I think.
And I think right from the spectrum, I mean, right from when to suspect them, how to go about diagnosing them, the list of investigations, Sir didn't leave out any of the simpler ones either. I mean, and then telling us about genomics. Targeted panels were the rage in the past, but I think the world is moving towards clinical exomes. They're more expensive, but they're also more high yield. So I think this has been a very enriching session. I agree with Dr. Harendra Agarwal. So I think with it's now 12:30, and if Kim ma'am permits, we will say thank you one last time to
Yeah,
Professor.
I think we should call it a day. Thank you very much, everyone who had attended the session, and also Dr. Mishra for working so hard for me and for Dr. Asranti. Thank you very much. Hi, Dr. Datta Gupta. Hello.
Yes, madam.
you.
He might tell something.
Doctor,
Siddharth sir is there.
Nice
Yes,
to
madam.
see you.
No. I
Thank
just
you.
wanted
Thank
to
you very
appreciate
much. Bye bye, everyone. Bye bye.
Mishra
I'm logging
and
off.
Dr. Prashant. Thank you very much.
Thank you, Professor Kim and Dr.
Yeah.
Asranti and everybody
Son.
for organizing such periodic
Very
meetings
good.
to educate people.
Yes.
Yes.
Thank you all.
Thank you, Dr. Mishra, for